right, so I wanted to talk about something that probably a lot of women experience in the room. It is a slightly short time, so I want to talk about endometriomas, but I think in order to even get to endometriomas, we should talk about physiologic cysts, sort of how cysts form, something like hemorrhagic cysts. So let me just get started. All right, so I have no disclosures related to this talk. Before we start with cysts, let's quickly talk about the ovaries. Okay, so remember the ovaries, they're typically paired endocrine organs, meaning they produce hormones. They're positioned on either side of the uterus. They actually weigh only 4 to 8 grams each. These are normal ovaries, and they measure roughly 1 by 2 by 3 centimeters. So they're sort of the size of almonds. So if you think about that, you have 2 almonds that are very, very powerful in generating a lot of this. So during puberty, remember the brain stimulates the ovary to cause maturation of follicles. So these are eggs, okay? Menarche is the age at your first period, so on average that is about 12. For the majority, periods become regular after 3 to 4 years, and we know that the average age of menopause in the US is about 50 to 51. So this is I don't know if it's a fun fact, but it's a fact. Women have about 400 to 500 periods in their lifetime, and that's equal to about 6 years of their lives. So this is a depiction of an ovary. It's sort of a ovary sort of through the menstrual cycle. If you start here on this upper right-hand corner, what you're seeing there is sort of the early follicles. If you follow that counterclockwise, what you're gonna do is you're sort of following the ovary through the follicular phase. So remember, during the follicular phase, estrogen is rising, you're recruiting eggs. In the beginning, you have quite a few eggs towards what we call ovulation. Typically, so the midpoint of the cycle, we are selecting what's called a dominant follicle, so sort of the best egg of the bunch, okay? And remember, for ovulation to happen, that egg is released, okay? That egg is released, potentially it travels down the tube for implantation, to meet the sperm for implantation. So the site of ovulation then regresses. Well, then it becomes something called the corpus luteum, which is very, very important. This is also a hormonally active structure. And unfortunately, if it doesn't, see fertilization, implantation, it becomes something called the corpus albicans, which is honestly very challenging to see, but you can see it on things like pathology reports. Okay, so the corpus luteum, remember, this is a normal structure. So temporary endocrine organ, it secretes progesterone, other hormones, it protects the egg, allows time for fertilization, implantation. If fertilization happens, then the egg is gonna make its own hormone, beta-HCG, keep that corpus luteum talking, producing progesterone, and then the placenta will take over around 9 to 10 weeks. Okay, so this is what a corpus luteum looks like on ultrasound, okay? And there's a couple of appearances, but on average, it measures about 2 centimeters. It's this round hypoechoic, meaning low echo structure. It has something called peripheral vascularity. So that means it's, has vessels on the outside. So it has this sort of ring of fire sign. It can also look like this. So this is sort of what it looked like in the drawing. So it's thick-walled. Those walls tend to be irregular, poorly defined. It looks like it's collapsing in on itself, right? Okay, so remember, those are the things that are normally happening anyways, okay? Now, 20 to 30% of women will have an ovarian cyst in their lifetime. But of course, we know the actual prevalence is unknown because most of those cysts are gonna be asymptomatic, potentially, benign, but a lot will resolve before they're even found, okay? 4% of women will be admitted to the hospital for an ovarian cyst by the time they're 65, and the common symptoms, unfortunately, are very common, so they overlap with a lot of other conditions, but they include bloating, nausea, abdominal pressure, painful periods, urinary symptoms, painful intimacy, back pain. Okay, now the first type of cyst, okay? So this is a follicular cyst, okay? So this type of cyst basically occurs when the follicle continues to grow and it doesn't rupture, so you don't ovulate, it keeps growing. And so on ultrasound, it's typically bigger than 3 centimeters, okay, because a normal mature follicle measures around 2.5 centimeters. So it has these very specific characteristics. Most typically it's unilocular, meaning it's like one loculation, one area, anechoic, meaning no echoes, and it's smooth-walled. So basically, if you ever are looking over at what the sonographer is doing, it basically looks like a black water balloon. Okay. Okay. So a corpus luteum cyst occurs when the corpus luteum fails to go away. So it fails to involute, and it actually just keeps getting bigger. Okay, so this is more common in women using ART, meaning assisted reproductive technology, IVF, egg freezing. And then this is what is important as well. So both of these types of cysts, they have vessels in them, they have vascularity. I just talked about this ring of fire. So they can both become something on the right-hand side called a hemorrhagic cyst, okay? And some people may be more familiar with this because a hemorrhagic cyst looks very similar to an endometrioma on sonogram, okay? So after some internal bleeding, this has this sort of lacy reticular pattern that you can see here. Unfortunately, hemorrhagic cysts also have a pretty variable appearance. They can look like that. They can also have this sort of dense solid nature. They can have what's on the bottom, so it has mixed sort of cyst-solid patterns. It's more commonly found in the second phase of your cycle. But the important thing to know here is that hemorrhagic cysts, all of these cysts tend to go away, so they tend to resolve, okay? So then that actually brings us finally here. So this is our endometrioma, okay? This is our chocolate cyst. Okay, so of course, well, I'll speed up too. So this forms really from the seeding of the uterine lining to the ovary, and it causes this repetitive cyclic hemorrhage process. Okay, it creates this very pathognomonic, sort of like Hershey's chocolate cyst fluid, okay? 25% of endometriosis, roughly, okay, will form an endometrioma, and about 25% of those are gonna be bilateral, okay? And they have this very classic appearance. We call it ground glass. Oops, that's the wrong thing. Same thing, ground glass appearance, but you can see how it kind of looks similar to that hemorrhagic cyst that we just saw. Okay, aside from the actual symptoms, which I won't go into right now, what impact does having an endometrioma have? So one of the big ones is, unfortunately, it decreases your ovarian reserve, your ovarian function. How do we think that happens? There's a couple of mechanisms here. That sort of the two biggest one is, number one, we think, imagine now that ovary I just talked about, the size of an almond. If you think you have a 5-centimeter endometrioma, unfortunately that cyst is so large, we imagine there's compression of that healthy ovarian tissue. Impairs the circulation, can cause some ischemia, overall, unfortunately, damaging the ovarian reserve. Also, of course, this cyclic inflammation causes scar tissue and damage over time. Okay, so very important here. So how do we measure the ovarian reserve? So some of you might be familiar with this. We use a number of measures, but these are two of the most common. So a hormone is called, a blood test, sorry, is called the anti-Müllerian hormone, AMH. It's a hormone produced by your growing follicles. The REIs, the fertility specialists, tend to use antral follicle count as well, where they're actually counting the number of the follicles. But what we do know very generally is that if you, sort of the larger the endometrioma that you have, the lower your AMH, so the lower your ovarian reserve. They also did a good study where they took, women with endometriomas, women without, and they measured their AMH over time. So they saw, okay, the women with endometriomas, their decline in AMH is also faster. So just by nature of the size and how long they're having them there is impacting the ovarian reserve. Okay, I use this chart a lot with my patients, but they looked at, almost 3,000 patients and looked at sort of the mean AMH, okay, for age. So, if you're age 25, the median AMH is about 5.4. Okay, if you're 30, that median is about 3.5, 35, 2.5, and at 40, 1.2. So again, this is a surrogate marker. It's not, this obviously taken contextually with the patient, but it gives us a very rough estimate, especially if fertility is very big on a patient's mind, okay? So if they're at maybe the 10th percentile or lower for their age, in the context of endometriomas, it could be a very important time to have some counseling, okay? In general, not just endometriomas, but endometriosis in general does have a decrease in spontaneous fertility. So we typically say fecundity is the chance of conceiving each cycle. Normal fecundity is about 15 to 25%, depending on your age. and rates of fecundity are extrapolated to be anywhere from 2 to 10% with endometriosis. So it's not that you cannot get spontaneously pregnant, okay? It's just that it may be more challenging, okay? And obviously there are things that, delay time to pregnancy, in our modern world. Okay. Can an endometrioma resolve spontaneously? So typically, no, we don't think they can. So if, sometimes I have women say, oh, I had an endometrioma 3 years ago, they saw it on the ultrasound, but, it went away. Sometimes two things. One is perhaps it was a hemorrhagic cyst. It's really hard to tell, especially with old imaging. The other is that potentially that endometrioma ruptured or leaked, which is its own host of problems. But in general, we say no, they don't typically resolve. Can hormonal medication help? So also this, we say generally, no, it's not going to resolve the endometrioma, but it can prevent growth. It's actually a very, very important part of recurrence risk that I'm about to talk about, and it can shrink them moderately. So if you have a very small endometrioma, you may be a candidate for medical management. So our best options, unfortunately the first one is not available in the US, it's Dynagest, and the second one is norethindrone, which is a very strong progestin. Probably many of you are familiar with it. Unfortunately, it does have a pretty strong side effect profile. So, all right, very quickly, surgical options, okay? And this is, again, a generalization, but the first two, ovarian drainage, where the cyst is ruptured, drained, and then sometimes burned, okay, is what some practitioners are doing. The second is an ovarian cystectomy, where we actually take the wall of the cyst, fully peel it out, and repair the ovary. The last one is something called ovarian sclerotherapy. It's gaining a little bit of traction, I think more in Europe. We don't have so much time to talk about it, but it essentially involves putting the ovarian bed, sort of the cyst wall, basically in ethanol. Since it's not standard of care right now, I'm not going to go too much into it, but people are trying to develop ways, okay, to reduce the risk of, damage to the ovary anytime we do surgery. So, people, again, are still, even on the surgical front, and they're pushing very hard on the medical front, but trying to find ways to, make our surgeries better. Okay, so this is a picture of the pelvis at the time of laparoscopy, and this is a very nice looking pelvis. There's a uterus in the middle, okay, that's the central structure, and if you look on just below that on either side are the ovaries, those white structures, and then you're gonna see fallopian tubes just lateral to that, okay? So this is an example of an endometrioma, and you can sort of appreciate this implant that's already seated itself. You can see this increased vascularity, okay? This looks like this just looks angry, okay? And inside you will find that very classic chocolate cyst fluid. You can actually, if you have a keen eye, you can see there's actually an adhesion already forming back here, okay? And actually look at where we are. This ovary is actually already pulled medially, okay? So it's already pulled to the rectum, okay? So this process is starting, this repetitive cyclic process, inflammatory process. And then unfortunately, if you leave these things unchecked, you could develop more, a bilateral endometrioma. Unfortunately, in this patient, you can see not just that obliteration of the normal sort of pelvis, but if you look carefully here too, you can actually see that tube going into this space. So unfortunately, this tube was already too involved at that time, okay? And this one is just a slightly bit more dilated, but looked fine. Okay, so in general, we would say, if you do a comparison to drainage versus cystectomy in general, I would say that most endometriosis surgeons are gonna prefer ovarian cystectomy for a number of reasons. You have a lower cyst recurrence, okay, which is very important, and you have a lower symptom recurrence. So in general, in those two situations, it's a win-win. Also, spontaneous fertility at about 1 year, they don't really suggest a difference. The reason that some people are hesitant, again, is this, are you damaging the ovarian reserve anytime you do surgery? Yes, but from what we just learned, if you leave it there, or if they recur, unfortunately, they do damage on their own, right? So you just need to find a place that's gonna treat the ovary with respect, use very minimal cautery, et cetera. Okay, good, last slide. So should you give hormonal therapy to prevent recurrence? There's a little bit of controversial ideas, but in general, yes, okay? Ovarian endometriomas, if you do not do anything, will recur in about 27 to 30% of patients in only 2 years, okay? So you really don't want to keep doing this type of surgery over and over again. I mean, medication is not perfect, but it's better than nothing, okay? They did a very nice study in 2010. They took about 240 women who underwent cystectomy and they followed them out for 24 months. So they found a similar rate. So if you didn't use any birth control, the recurrence rate was about 29%. If you used birth control but you took it cyclically, meaning you took that placebo pill, your recurrence rate was better, but it was still 15%. So it was only with continuous use, where you're taking hormones every day, that they got the recurrence rate down to about 8%. The good thing that we noted too was that if you were taking some form of hormonal pills, if you did have a recurrence, at least that recurrence was smaller, okay? So that was a really important point. Of course, women have different and independent risk factors. It's not just medication. So early age, if you make bilateral endometriomas, if you make more than one endometrium on an ovary, those are all risk factors. Okay, and obviously the type of surgery you have. Okay, I just hit. Okay, in summary, so each menstrual cycle, a dominant follicle and a corpus luteum form, okay? Functional cysts, okay, cysts that happen physiologically are follicular cysts, corpus luteum cysts, and they can both create hemorrhagic cysts. Unlike endometriomas, these cysts tend to go away. Endometriomas unfortunately cause a decline in ovarian function and spontaneous fertility. We will have some very good fertility talks later today. Endometrioma should be treated with cystectomy rather than ablation and drainage. And then medical management and follow-up is important for endometriomas given their recurrence risk, okay? These are some references. Okay, I wanna thank everyone for coming.